This topic is very important from the practical point of view and also from examination point of view. Anesthesia for non-cardiac surgery in patients with cardiac disease is something we have to perform almost every day as anesthesiologists. Anesthesiologists have been getting this challenge of having difficult patients who've got severe heart disease coming for surgery. And this number is increasing over the last few years and is going to increase further in the next few years. So what are the lecture objectives? Firstly, we'll talk about the coronary perfusion because understanding coronary perfusion is important in case you want to talk about coronary artery disease. Secondly, we talk about preoperative assessment and optimization for patients who have coronary artery disease and who come for non-cardiac surgery. Third, we'll discuss various preoperative risk factors which a patient has and how do we grade the risk of a patient for the surgery. Next, we'll discuss the anesthetic consideration and how we should manage the anesthesia for these patients. And lastly, we talk about the post-operative considerations in these patients. Coming back to the importance of this topic, I would like to remind you that a large number of patients presenting for surgery today are above 65 years of age. The surgical population profile is gradually shifting towards the right, and this number is going to increase by nearly 25 to 35% in the next 1 or 2 decades. It is estimated that perioperative ischemia occurs in 18 to 74% of patients who've got ischemic heart disease and who come for non-cardiac surgery. 60% of the patients who die within 30 days of surgery have got evidence of coronary artery disease. Coming to the next part of the lecture, that's understanding coronary perfusion. As I said earlier, the coronary perfusion physiology should be well understood by anybody delivering anesthesia to a patient with coronary artery disease. The large part of the arteries on the epicardial surface of the heart are called as epicardial arteries. They are branches of these epicardial arteries which penetrate into the myocardium and form a network of microvascular structure, which is the endocardial plexus. The name coronary is derived from the word corona, which is a Latin word meaning crown, garland, or wreath. It is applied to coronary arteries because they encircle the heart like a wreath. In case of partial blockade or a complete blockade of the epicardial vessel, the patient can always get a transmural ischemia, or in case the blockade remains for a long time, and can also cause a transmural infarction. Transmural infarctions lead to myocardial wall fibrosis, and because of myocardial wall fibrosis, these patients develop Q waves in the ECG. The presence of Q wave in an ECG is basically an indicator of fibrosis, which is of transmural nature. In case you have just a reduction in blood supply to the endocardial plexus, we call it as subendocardial ischemia or infarction. Such patients do not have Q waves, but because they do not have Q waves, it's called as a non-Q wave MI. A little bit about the arteries. The coronary arterial system has got 2 major arteries, the left coronary artery and the right coronary artery. The left coronary artery supplies the 2 branches, using 2 branches, and they are the left anterior descending artery, the LAD, which is also called as the widow's artery because this is the main artery which leads to death in case it's blocked. So that's why it's called as the widow's artery. And the next branch, important branch of the left coronary artery is the left circumflex artery. The right coronary artery supplies the right side of the heart. It usually gives branches to very important structures, that is the SA node and the AV node. In addition to it, the main branches of the right coronary artery are the ramus intermedius artery, the right marginal artery, and the posterior descending artery, which is also called as the PDA in common parlance. Another thing to remember is coronary dominance. What is the concept of coronary dominance? Coronary arterial dominance is defined as that artery which supplies the inferior third of the interventricular septum, and or it can also be called as the artery which is dominant supplies the or forms the posterior descending arteries. The artery which mainly forms the posterior descending artery is considered as the dominant artery in the coronary system. In 80 to 85% of the hearts, the RCA is the dominant artery as it gives rise to the posterior descending artery. At times, the posterior descending artery is formed by a combination of or equal contributions from the left coronary artery and the right coronary artery. Then such a circulation is said to be called as co-dominant circulation. The heart, remember, receives 5% of the cardiac output at rest. That is about 250 ml of blood per hour. The cardiac output can increase by fourfold in case there is an increase in demand on the heart. Another important thing to remember is that the perfusion of the coronaries is inverse phasic in nature. What do we mean by this? See, most organs of the body receive the perfusion during systole. However, the same is not so in case of the coronary arteries. The coronary arteries perfuse during diastole. Why is this so? Because the coronary ostia get occluded by the open AVV, aortic valve leaflets, and it prevents coronary filling during systole. As a result, it is very important to remember that the diastolic filling time is a very important phase of the cardiac cycle as far as coronary filling is concerned. Because all the filling is occurring during diastole. Now, in case the diastolic time is shortened, as it happens in tachycardia, the supply of blood to the coronaries is drastically reduced. Another thing to remember is during cardiac systole, the coronary arteries are compressed by the compression of the myocardial muscles. And this is especially so in the left ventricle and the subendocardial region. So left ventricle and the subendocardium, the transmural area of blood supply cannot happen because of the contraction of the muscles during systole. So in this area in particular, the blood flow to the subendocardium occurs only during diastole, that is in the left ventricle. The subendocardium is the most prone part of the heart as far as ischemia and infarction are concerned. And that is why the evidence of ischemia which you see on ECGs, that is ST depression, is evident basically because of a decrease in the blood supply to the subendocardium which is there. There's another phenomenon which is very important to know as far as anesthesia is concerned, that is the phenomenon of coronary steal. What is coronary steal? Coronary steal is said to occur when the perfusion is preferential to the vasodilated bed or the coronary bed. What do we mean by this? I'll explain it now. And this is generally seen in coronary steal prone anatomies. That means whenever there are plaques in a vessel or in some epicardial vessel branch, but the other branch is free of a plaque, then the blood will flow preferentially to that branch. And in case you give a vasodilator to such a patient, the normal vessel will dilate. That is, in this case, you can look at the P2. The P2 is likely to dilate in response to the administration of a vasodilatory agent. But because a plaque is there in the diseased vessel, this cannot vasodilate. So in case you give a vasodilator, the flow will further be stolen into the normal vessels, and it will be stolen away from the disease vessel, but will totally go into the normal vessel. You can see the same phenomenon here also. If you look at this vessel is normal, but if you look at these branches, this branch is having a stenosis, while this branch has got lesser amount of disease. So in case a vasodilating agent is given, then the blood will preferentially go to the R3 branch, but not to the R2 branch. So that resistance, here the R is showing the resistance. So resistance in R3 is less than resistance in R2. So the blood will preferentially flow into the R3 branch. So what I said earlier was the vasodilatory effect will dilate the plaque-free vessels, but not the atherosclerotic vessels with plaques. Steal, when does it occur? Steal occurs whenever you administer a pharmacological agent and it dilates the coronary arteries. Steal also occurs during exercise because of metabolic reasons. Again, because of metabolic reasons, the normal vessels dilate, but the abnormal vessels or the ones with disease do not dilate. And that is that the patient develops angina in a case the patient undergoes some exercise. Coronary steal typically occurs under anesthesia with the use of NTG and with the use of inhalational agents like isoflurane, which are vasodilatory. Now coming to the pre-operative assessment of patients. In case the surgery is an acute emergency, preoperative evaluation of such patients is generally limited to rapid assessment of the cardiovascular system, the vital signs, volumes, and just the electrocardiogram or the ECG. In case it is not an emergent nature surgery, then we can do a thorough examination of the patient and decide on the condition of the patient before we accept the patient for an elective surgery. In case the patient has got a major problem, we can even delay or cancel an elective surgery till a complete evaluation of the patient is done. As far as the history is concerned, in such a patient, we should identify serious conditions such as angina, recent or past MI, congestive heart failure, and look for evidence in history of symptomatic arrhythmias. We should recall all risk factors which are related to ischemic heart disease. In the history, we should definitely document any change or recent change in symptomatology of the patient. We should always record the current medication and the dosages, the timing of the at which various drugs are given, because that will help us decide which drugs have to be given preoperatively to the patient. We should determine the functional capacity of the patient. This is something very important. The functional capacity gives you a very good idea about how the patient will behave intraoperatively and postoperatively. Continuing with the preoperative assessment, you should always look for signs of cyanosis, pallor, dyspnea during conversation or with minimal activity, nutritional status of the patient, especially look for obesity, skeletal deformities of patient, tremors and anxiety in patients. We should always look for signs of acute heart failure. Signs of acute failure, what are the common signs? Look for rales and changes in the X-ray chest. Also look for signs of chronic heart failure. The signs of chronic heart failure commonly we look for is a rise in the JVP or a positive hepatojugular reflex with or without the presence of pedal edema. The functional capacity assessment and the level of surgery assessment should be done very carefully because it helps us decide the risk of the patient and also helps us decide how we should assess the patient further and decide whether the patient requires further investigations and further evaluation. Generally, we consider the functional capacity as a very reliable predictor of future cardiac events. Remember, we can classify the patient's risk or the safety of the patient's surgery as excellent in case the METs of the patient are more than 7. In case the patient has METs between 4 and 7, we can say that the risk is moderate. And in case the METs are less than 4, then the patient's risk is very high, and that means the patient has got a poor risk for surgery. And this less than 4 METs is considered as a tipping point. In case the patient has got METs less than 4, we should be very careful about the risk assessment. At times, the risk assessment based on functional capacity cannot be done because the patient is bedridden or has a disability and is unable to walk. Here we classify the risk as the functional capacity as unknown. Coming to preoperative revascularization, whether it should be done or not. Many of us feel that in case the patient is coming for non-cardiac surgery, we can subject the patient to revascularization before doing any major surgery. However, studies have shown that there is no added benefit of prophylactic coronary revascularization. We should attempt or contemplate pre-surgical revascularization, that is CABG or coronary angioplasty, only in patients who've got a high-risk coronary anatomy and who are undergoing major surgery of elective nature. What are the high-risk anatomies which we see? The indication that is indications for pre-surgery revascularization: a left main stenosis, or a 3-vessel coronary artery disease which is associated with LV dysfunction, a 2-vessel coronary artery disease with a proximal obstruction of the LAD, or in case the patient has got an intractable ischemia despite medical therapy. Also look for comorbid conditions in patients, because the associated comorbid conditions often heighten the risk of anesthesia and may complicate the cardiac management of the patient. Which are the common comorbidities which we should be afraid of or we should look for? Number 1, we should look for obstructive or restrictive pulmonary disease, because that disease increases the chances of perioperative respiratory complications in these patients. We should look for hypoxemia, hypercarbia, and acidosis, which an increased work of breathing, which will be there in case the patient has got pulmonary involvement, and this is likely to cause a lot of cardiac events in the perioperative period. In case a significant pulmonary artery disease, or pulmonary disease is suspected, you should always determine the functional capacity and optimize the patient clinically before you take up the patient for a non-cardiac surgery. The next disease which has serious consequences is diabetes mellitus. In case the patient has got diabetes mellitus, we should always suspect the presence of a silent myocardial ischemia which can occur perioperatively or may have occurred preoperatively. So another thing to remember also is that in cases patients got diabetes mellitus, it may be difficult to manage the blood glucose level in the perioperative period, especially in case the patient is a fragile diabetic, that is on short-acting insulin already. Stable diabetic patients may be treated with long-acting insulin or oral agent, but remember, we should maintain a tight periglycemic control of the patient intraoperatively. What I mean by tight periglycemic control is maintain the blood sugars between 120 to 160, not 80, 120 to 160. You should not have hypoglycemia also. So maintain a tight periglycemic control between 120 and 160, because hyperglycemia can cause multiple complications. The next organ which we should look for is the kidney. We should look for renal impairment in such patients, because renal impairment is commonly associated with coronary artery disease and often complicates its management. It is in these patients that it is very difficult to maintain adequate intravascular volume for maintaining the renal perfusion, because the patient may be on diuretics, may be on some agents which affect the renal perfusion. So you should be very careful, and excessive diuresis remember, in combination with ACE inhibitors, may cause a rise in the BUN and the plasma creatinine level. So we should be aware of this problem because these patients may be on ACE inhibitors. The next organ we should be worried about is the hematology or the blood. Remember, anemia poses a severe stress on the CVS because it causes tachycardia, and tachycardia exacerbates myocardial ischemia and congestive heart failure. Tachycardia causes an increase in the oxygen demand of the patient in a patient who's already got a reduced oxygen supply to the coronary arteries. And in addition, patients with anemia have also got a reduced oxygen carriage capacity. So tachycardia can be very bad for patients with coronary artery disease. So it is sensible to do a preoperative transfusion in such a case, in case it's appropriate, of course, in patients with coronary artery disease with or without congestive heart failure, because a preoperative transfusion to get to an optimum hematocrit will help us reduce perioperative cardiac morbidity.